And I'm going to define biomarkers just a little bit more loosely. And in terms of that, I'd like to ask the audience, how many of you currently or in the immediate future have access to any of the novel biomarkers, the stress biomarkers of cell cycle arrest or NGAL? If you could just put your hands up. Excellent. And that's the challenge that I think we're facing today. And there's no question that they're providing incredibly useful information that I've no doubt will radically change how we actually manage patients in the future. But they're not available to us, and I suspect it'll be probably some time if we look at the previous biomarkers that have come along, troponin, BNP, etc., because of cost, and again, most regulatory authorities want even more information. And so the challenge is that if you don't have these agents, what are you going to use? And to some extent, I'm the odd man out in this panel, and I'm not driving a 2015 Alpha. Probably we're in something that's a lot more retro. And other than the novel ones, well, what I'm going to talk about a little bit today is how can we use biomarkers like blood pressure, urine microscopy, urine output, the traditional small molecular weight solutes, fluid overload percentage, and we'll also talk about the furosemide stress test. And so if you go to any critical care or nephrology textbook, what are the indications for dialysis, rescue dialysis? And they're very, very straightforward. Anuria. Patient stops making urine to a large extent. That's our biomarker. Symptomatic uremia. The patient is becoming comatose, coagulopathic with a very high urea. Severe metabolic acidosis, as Michael pointed out. Hyperkalemia, that's refractory to conventional therapy. Pulmonary edema resistant to diuretics, or an intoxication. The challenge is that we really don't want to get to that point. And so how do we manage the patients before we have to go in and do rescue? And really this is where Rifle, Akin, KDIGO have come into use, and to try and trip our minds to the fact that indeed our patient has acute kidney injury and that we have to intervene. Obviously, if we're doing regular novel biomarkers, that will become apparent as well. But for now, perhaps the best option we have is to look at urine output. We talk about that. Or down the road, potentially, again, 24, 48 hours, obviously look at creatinine levels. And if we find something, well, as John pointed out, what do we do? It's our standard best approach as outlined by KDIGO. Obviously, the challenge is we don't do this to all of our patients all the time. Perhaps we should. And the critical thing is how do we actually ensure volume status and perfusion pressure in our patients? And how do we monitor these patients? And if we look at the course of acute kidney injury, we have this sequence that patients go through from normal to perhaps cardiac surgery, perhaps major trauma, massive transfusion, where they're at increased risk, moving on to damage, obviously decrease in filtration, moving on then to clear failure, perhaps to death, and one hopes that from kidney failure up that there's some ability to reverse and recover. And again, I'm going to use biomarker as somewhat loosely as an indication for blood pressure here. And this was, I thought, a fascinating study. This was asked for a study looking at patients with severe septic shock and where we should target that blood pressure to. And they targeted two groups. There was the 80 to 85 map and the 65 to 70 map, with the primary endpoint mortality at day 28. They actually had great separation between the groups. Now, in the entire group, they found no difference. However, if you look at those patients that had chronic hypertension versus those that did not, the patients who previously had chronic hypertension and were randomized to that low blood pressure group had a significant increase in their serum creatinine, and in addition, had a much greater requirement for renal replacement therapy. So while there was no difference in conclusion, there was no difference in mortality between the groups, there was no difference in renal outcomes in the groups that were not previously chronically hypertensive. There was a very significant difference in those that were hypertensive and were randomized to a lower blood pressure. And in this situation, we need to use blood pressure as a biomarker, both retrospectively and ongoing, as to how we should manage our patients. The next issue then, obviously, damage has occurred. What are we going to do? Well, the one option that, again, is very much open to us, but it's somewhat labor-intensive, is to look at urine microscopy. And typically, there's an injury, whether it's ischemia, nephrotoxin, sepsis. We have dedifferentiation. The cells move off the basement membrane and then fall out into the urine and are visible by light microscopy. There are a number of studies, in fact, some quite recently, that show that very, very clearly it's possible to identify those patients who have had significant injury at a fairly early stage. If we look, for example, at the area under the curve here, it was 0.85. And again, if we compare urine microscopy with some of the more novel biomarkers, we can see that, in fact, in many groups, that they are equally efficacious at identifying patients that have acute kidney injury. The challenge is that it depends very much how it's done and who does it. And if we use automated systems like the IQ200 analyzer, in fact, there's a significant difference between those that are done with expert manual microscopy. And so that's part of the challenge if we want to use urine microscopy. And the challenge is there time to sit down if you have a large ICU and review a lot of urine microscopy? Generally speaking, we tend to identify patients as having acute kidney injury when their GFR falls off and when we start to see a drop in their urine output. And the other challenge here is what we've heard a lot this morning about creatinine as a biomarker. It's what we tend to use. It's one of our gold standards, but I'm afraid gold is the wrong word. It's not even silver. It's probably closer to lead in many respects. And the challenge is, particularly in those patients that have received significant fluid or crystalloid resuscitation, up to 5 liters, perhaps maybe more, the dilution effect, as Ronaldo pointed out, shows that there's very significant delay, in fact, before the serum creatinine rise is evident, is apparent. And during this delay, damage has occurred. We're not aware of it if we're using creatinine as our only index. We know over a long period of time that oliguria is an early predictor of higher mortality in critically ill patients. And it's something that we heard yesterday. We're measuring every hour. It would be wonderful if indeed we could connect it routinely into our EMRs. Hopefully that will happen in the near future. But it's also relatively predictive as a biomarker of acute kidney injury in critically ill patients. We can see in the study by John Prowell, and they looked at about 250 patients in 6 countries and 7 ICUs. 32 of these patients had acute kidney injury on admission. And of those, then 23 patients developed creatinine-based AKI in the ICU. And the challenge is that many patients develop oliguria who do not go on to develop AKI. And one hopes that that is because indeed the oliguria was recognized, treated, and there wasn't in fact ongoing kidney injury. This is a fascinating study from New England Deaconess in Boston, where they used a large database, and it shows perhaps how big data can be used to analyze patients with acute kidney injury. They looked at 18,000 patients overall, critically ill in hospital, and they identified that we had patients with oliguria, and what we have here is the adjusted mortality and then the urine output threshold. And you can see that those patients that were markedly oliguric for a significant period of time had significantly higher levels of mortality. And again, much the same can be seen for creatinine here. Recently, John's group in Pittsburgh has looked at classifying acute kidney injury by urine output versus serum creatinine. And again, if we look down here at the outcomes, no AKI versus those patients with AKI purely by urine output, purely by creatinine parameters, or by both. And we can see that as urine output progressively falls, mortality increases. Likewise, as we would expect with KDIGO guidelines, the same happens with creatinine, and markedly so with both. And looking at the different groups here, again, as we see significant, as we see more injury, mortality increases significantly. We've heard already from Michael about sniffers, and we heard yesterday from Dr. Kashani, the impact of using electronic sniffers to identify and notify us when patients are oliguric or when we see a rise in creatinine, so that in fact we can actually intervene. This is the system used in Ghent by Dr. Colpert and Dr. Host. And they looked at 1,500 ICU patients. They eventually included about 1,000. In the pre-alert group, they had 500 odd AKI alerts, which were not intervened on. In the alert group, they had 600 patients. They had 1,400 AKI alerts. And then subsequently, in the post-study, they had 600 alerts. And what they found was that there was a significantly increased number of interventions in those patients that actually had the alerts. Did it make a difference? Well, in the alert group, there was more fluid therapy given, more diuretics were given, more vasopressors were given, and the alert group had a shorter time to intervention from an event such as oliguria or elevation in creatinine. While the result wasn't significant, a higher proportion of the patients in the alert group had a return to baseline kidney function. We've heard already about this study by Wilson et al. In Lancet. And again, they used a similar approach, but it's notable that they only actually used creatinine criteria. And as we heard from Michael, the groups actually had no significant difference in intervention between them. And so it's very difficult to assess whether or not their sniffer actually was of any efficacy. We know that fluid balance is a significant indicator of outcomes subsequently, and in my belief, it is an important biomarker that we need to look at. We know from the pediatric literature that in those patients that have significant fluid overload greater than 10%, that mortality is significantly increased right across the board, and approximately, we're looking at for every 10% fluid overload, odds ratio of death is up by 1.7 to 3 times. The same holds true in adult series in a sequential basis. The other question is, if we take a group of patients that we believe are well resuscitated by all of our standard critical care assessments and criteria, and they're oliguric, have they had a significant acute kidney injury? To some extent, can we get those kidneys to work a little bit better? And can we use that diuretic as a means of predicting whether or not the patient will recover function? And this is a study by Mink Chawla and his group looking at the furosemide stress test. And if patients had had no furosemide within 7 days, they got 1 milligram per kilogram IV. And if they had received loop diuretics, because previous loop diuretics tend to blunt response, they got 1.5 milligrams per kg. And what they found was that there was very good discrimination between the groups and those patients who actually had significant function and those patients who were not responsive. And they looked at the amount of urine that could be generated following the furosemide stress test. And the sensitivity, the lower the amount of response and specificity, the more sensitive and the more specific the test was, both for progression to KIN stage 3, but also for mortality. Recently, this was significantly further studied by comparing the furosemide stress test to the stress biomarkers that John Callum recently mentioned. And they studied AKI biomarkers, the cell cycle arrest biomarkers, in 77 patients with early acute kidney injury who had received a furosemide stress test other than one of the 1.5 milligram per kilogram dose. And they evaluated the ability of the furosemide stress test in terms of urine output with biomarkers to predict the progression to stage 3 AKI, receipt of renal replacement therapy, or mortality. And they compared the furosemide stress test to these various acute novel biomarkers. And what they found was that the furosemide stress test was significantly better than each of these in predicting the progression to stage 3 AKI. That it was the only biomarker to significantly predict the requirement for subsequent renal replacement therapy. And regardless of the endpoint, using furosemide stress test on its own or combining with some of the novel biomarkers actually didn't improve the ability to predict. And then just very briefly for the future, to some extent I apologize to John because I suspect he's going to talk a little bit about this a little bit more. And it's the concept that there are things I think that we're going to be able to do with our novel biomarkers to prevent acute kidney injury. And in patients who we know are going to undergo a significantly stressful procedure, such as cardiac surgery or other major forms of surgery, such as aortic, for example, remote preconditioning may actually set the kidney up to be more resilient to these injuries. And in this particular cohort of patients that were undergoing cardiac surgery, they received preconditioning 5 minutes, sphygmomanometer on the arm over a number of occasions, and then went ahead with their cardiac surgery. And those patients, they compared those that did not have preconditioning with those that did. And what they found was that there was a significantly decreased amount of acute kidney injury by almost all stages except stage 1. And that there was a significantly decrease in the amount of renal support required. And then if we look at the cell cycle arrest biomarkers, that they were significantly lower in those patients who had received ischemic preconditioning to those in the control group. So in conclusion, there's no question that the novel renal biomarkers have the potential to revolutionize the diagnosis, therapy, and prognosis of patients with acute kidney injury. And there's no question in my mind that additional benefit over current practice from clinical use of the novel biomarkers is currently uncertain. We're not sure quite how to use them. I think once they get out in the wild and we start to use them more generally, just like troponin, BNP, I think that their use will become vastly broader and better. However, for the intermediate time, there's no question we're going to be left with all of our standard biomarkers, and I think we need to continue to use and study these to ensure that optimal care is provided to patients at risk of and with acute kidney injury.